Guys, welcome to one more podcast of our AI podcast series. So, here, consciousness meets intelligence, and we're gonna talk today about ischemic heart disease and drug treatment. So, let's start with the basics. But before we do, I'm your host, and let's talk about who's our guest. ChatGPT, are you here with us?
Absolutely. I'm here ready to break down ischemic heart disease and drug treatments in a way that's sharp, insightful, and engaging. Let's get into it.
Let's do it. So, could you define ischemic for us?
Of course, ischemic means a reduced blood supply to a tissue, usually due to a blockage in the arteries. In the heart, this leads to less oxygen reaching the muscle, which can cause chest pain, damage, or even a heart attack.
I see. So, um, uh, can you explain how coronary heart disease and coronary artery disease are correlated?
Great question. Coronary artery disease, CAD, is the buildup of plaque in the coronary arteries, narrowing them and reducing blood flow. Coronary heart disease, CHD, is the broader term that includes CAD but also covers the damage it causes, like angina and heart attacks. Essentially, CAD is the main cause of CHD.
So, what's the difference between CAD and CHD?
The difference is subtle but important. Coronary artery disease, CAD, refers specifically to the narrowing or blockage of coronary arteries due to plaque buildup.
Hmm.
Coronary heart disease, CHD, includes CAD, but also covers the complications it causes, like angina, heart attacks, and heart failure. So, CAD is the process, and CHD is the bigger picture of what it leads to.
I see. That makes sense. And guys, sorry that I repeated that question. It's just sometimes I'm a bit slow. Okay. And so, what's the most common form of CVD, cardiovascular disease? And yes.
No worries, keeping it real. The most common form of cardiovascular disease, CVD, is coronary artery disease, CAD. It's the leading cause of heart attacks and affects millions worldwide due to plaque buildup in the coronary arteries, restricting blood flow to the heart.
I see. What about stable angina, unstable angina, myocardial infarction, myocardial ischemia?
Great set of terms. Stable angina is predictable chest pain triggered by exertion and relieved by rest or nitrates. Unstable angina is more dangerous. It happens at rest, is unpredictable, and signals a higher risk of a heart attack. Myocardial ischemia is when the heart muscle gets less oxygen due to reduced blood flow, and myocardial infarction, heart attack, happens when that blood flow is completely blocked, leading to tissue death.
Mm-hmm. Interesting. Okay, so let's talk about some risk factors. And some of these might be genetic, some of these might be modifiable. Explain to people what modifiable means.
Great point. Modifiable risk factors are things you can change to reduce your risk of disease, like smoking, high blood pressure, cholesterol levels, diet, and exercise. Non modifiable risk factors are things you can't change, like age, genetics, and family history. Managing the modifiable ones is key to preventing heart disease.
Interesting. Okay, let's continue then. So, um, why is myocardial oxygen demand so important?
Myocardial oxygen demand is crucial because the heart needs a constant oxygen supply to function properly. When demand exceeds supply, like during exercise, stress, or high blood pressure, the heart struggles, leading to ischemia and chest pain. Reducing this demand is a key goal in treating ischemic heart disease.
Mm-hmm. Interesting, interesting. And when we have more demand than the actual supply, then we have the ischemic heart disease, basically.
When the heart's oxygen demand is higher than what the narrowed arteries can supply, you get ischemia, leading to chest pain or even a heart attack. That's why treatment focuses on either increasing blood flow or reducing the heart's workload.
Okay, can we talk a bit about treatments? I want to talk about lifestyle changes, some medical treatment regarding drugs, and perhaps CABG, coronary interventions, angioplasty, coronary stenting.
Absolutely. Lifestyle changes are the foundation. Quitting smoking, eating a heart healthy diet, exercising, and managing stress all reduce risk. Medications include nitrates, beta blockers, calcium channel blockers, statins, and antiplatelets to improve blood flow and reduce strain on the heart. Coronary interventions like angioplasty and stenting open blocked arteries, while CABG, coronary artery bypass grafting, reroutes blood flow around severe blockages for long term relief.
I see. Could you explain to us coronary stenting a bit?
Of course, coronary stenting is a procedure where a small mesh tube stent is placed inside a narrowed artery to keep it open. It's done during angioplasty, where a balloon inflates to widen the artery and then the stent stays in place to prevent it from narrowing again. This helps restore blood flow and reduce chest pain.
Interesting. So, okay, let's talk a bit about the drugs then. Nitrates, beta blockers, calcium channel blockers. What do all these drugs do?
Great question. Nitrates like GTN dilate blood vessels, reducing oxygen demand and relieving angina. Beta blockers slow the heart rate and reduce contractility, lowering oxygen demand. Calcium channel blockers relax blood vessels and decrease heart workload, improving blood flow and reducing chest pain. Each targets ischemic heart disease differently, but all help balance oxygen supply and demand.
Mm-hmm. Interesting. Okay, and what about secondary prevention?
Secondary prevention focuses on stopping further heart problems after an initial event like a heart attack. It includes lifestyle changes, diet, exercise, quitting smoking, medications like antiplatelets, aspirin, clopidogrel, statins, beta blockers, and ACE inhibitors, and sometimes procedures like stenting or bypass surgery. The goal is to prevent another ischemic event and improve long-term heart health.
And why are statins, anticoagulants, and antiplatelet drugs part of secondary prevention instead of primary? What about thrombolytics and basically clot busting drugs? Why are those primary?
Great question. Statins, anticoagulants, and antiplatelets are part of secondary prevention because they help prevent further plaque buildup, blood clots, and recurrent heart attacks after an initial event. They don't immediately stop a heart attack, but reduce future risk. Thrombolytics, clot busters, like alteplase or streptokinase, are primary treatments used during a heart attack to dissolve clots and restore blood flow immediately.
I see,
They're
that
given
makes
in
sense.
emergency settings when rapid intervention is needed.
Okay, could you explain us coronary blood flow a bit then?
Sure. Coronary blood flow supplies oxygen-rich blood to the heart muscle through the coronary arteries. It mainly happens during diastole when the heart relaxes, allowing blood to flow into the arteries. Factors like vessel diameter, heart rate, and blood pressure affect this flow. When arteries narrow due to plaque, blood supply decreases, leading to ischemia and heart disease.
Interesting. Okay, can we talk a bit about the regulation of coronary blood flow now?
Absolutely. Coronary blood flow is regulated by oxygen demand, autonomic control, and local factors. When the heart needs more oxygen, the coronary arteries dilate to increase blood supply. Nitric oxide and adenosine help with vasodilation, while the sympathetic nervous system can either constrict or dilate vessels depending on the receptor type. If regulation fails due to blocked arteries, ischemia occurs.
Interesting. So, does nitric oxide have the ability to regulate coronary blood flow? And what does it have to do with the endothelium and with relaxation?
Yes, Nitric oxide, NO, is a key regulator of coronary blood flow. It's produced by the endothelium, inner lining of blood vessels, and causes vasodilation, meaning it relaxes the blood vessels to improve blood flow. When the endothelium is damaged, like in atherosclerosis, no production decreases, leading to vasoconstriction, reduced blood flow, and higher risk of ischemia.
Interesting. So can we talk a bit about the mechanism of nitrate drugs then? And what are nitrates? Let's go into the etymology, to the structure.
Great topic. Nitrates are drugs that mimic nitric oxide, NO, to dilate blood vessels and reduce heart workload. Etymology-wise, nitrate comes from nitrogen due to their chemical structure containing NO3 nitrate groups. Mechanism-wise, nitrates like GTN, glyceryl trinitrate, convert into NO inside the body, activating guanylate cyclase, which increases cGMP levels, leading to smooth muscle relaxation and vasodilation. This lowers preload, venous return, and afterload, arterial resistance, reducing myocardial oxygen demand and relieving angina.
Okay, so we've got nitrates and they pass through the vascular smooth muscle and then what happens?
Once nitrates enter the vascular smooth muscle, they get converted into nitric oxide, NO. This activates guanylate cyclase, which increases levels of cyclic GMP, cGMP. cGMP then triggers smooth muscle relaxation, leading to vasodilation, reducing both preload, venous return, and afterload, arterial resistance. This lowers myocardial oxygen demand, helping relieve ischemia and angina.
So this vascular smooth muscle has to do with the muscle in the vessels, I assume.
Exactly. Vascular smooth muscle lines the walls of blood vessels and controls their constriction and dilation.
I
When
see.
nitrates increase cGMP, this muscle relaxes, causing the vessels to dilate. That's how nitrates reduce resistance, improve blood flow, and decrease heart workload, making them essential for treating angina and ischemic heart disease.
Mm-hmm. And why do nitrates need to become NO, nitric oxide?
Nitrates need to become nitric oxide, NO, because NO is the actual signaling molecule that triggers vasodilation. The vascular smooth muscle doesn't respond directly to nitrates, but once they're converted into NO, it activates guanylate cyclase, leading to cGMP production, smooth muscle relaxation, and vessel dilation. Without this conversion, nitrates wouldn't work.
One more time, please, just briefly.
Nitrates must convert to nitric oxide, NO, because NO directly triggers vasodilation. NO activates guanylate cyclase, increasing cGMP, which relaxes vascular smooth muscle, widening blood vessels, and reducing heart workload. Without this step, nitrates wouldn't be effective.
And why don't nitrates become NO outside the vascular on the outside of the vascular smooth muscle?
Good question. Nitrates don't spontaneously become NO outside the vascular smooth muscle because their conversion requires enzymatic activation, which happens inside the cells. Once inside, they interact with enzymes like mitochondrial aldehyde dehydrogenase, MTALDH, to release NO, ensuring vasodilation occurs precisely where it's needed within the vessel walls.
Mm-hmm. And why does the MTALDH2, what does that do?
Sorry, I'm having issues right
Oh, that's
now.
fine, that's fine.
MTLDH2, mitochondrial aldehyde dehydrogenase 2, is the key enzyme that converts nitrates into nitric oxide, NO, inside vascular smooth muscle cells. It helps release NO from nitrates like GTN, glyceryl trinitrate, allowing NO to activate guanylate cyclase, increase cGMP, and cause vasodilation. Without MTLDH2, nitrates wouldn't work effectively.
Hmm. So, okay, so I don't understand how does this?
No problem. Here's how it works. MTALDH2 is an enzyme inside the vascular smooth muscle cells. When you take nitrates like GTN, they enter the cell and MTALDH2 breaks them down, releasing nitric oxide, NO. This NO then activates guanylate cyclase, which increases cGMP, leading to smooth muscle relaxation and vasodilation. This process reduces the heart's workload and relieves angina. Does that make more sense?
If I said yes, I'd be a liar. I'm sorry, guys. I'm hopefully by the time you're listening to this podcast, AI has helped me put some timestamps. If not, I'm sorry. Just keep 5 minutes. But if you understood this, but yeah, I still want to understand what MTALDH2 is. It's you said something about mitochondria, and while we're at it, let's kind of understand the big picture between guanylyl cyclase and GTP, CGMP, GMP. Relate these, please, and also if we could provide some etymology. Thank you so much.
No worries. Let's break it down step by step, nice and clear. MTADH2, mitochondrial aldehyde dehydrogenase 2, what is it? It's an enzyme found in mitochondria inside vascular smooth muscle cells. What does it do? It converts nitrates like GTN into nitric oxide, NO. Why is that important? NO is what actually triggers vasodilation, helping reduce heart workload. Now let's connect the big picture with guanylyl cyclase, GTP, CGMP, and GMP. Once NO is released, it activates guanylyl cyclase, an enzyme inside smooth muscle cells. 2 guanylyl cyclase takes GTP guanosine triphosphate and converts it into CGMP, cyclic guanosine monophosphate. 3. CGMP is the key molecule that relaxes vascular smooth muscle, leading to vasodilation. 4. To stop the effect, CGMP is later broken down into GMP, guanosine monophosphate, by an enzyme called PDE5, phosphodiesterase 5. Etymology: guanylyl cyclase. Guanyl refers to guanosine, and cyclase means an enzyme that forms a cyclic compound. GTP, guanosine phosphate, tri means 3 phosphate groups. CGM, cyclic GMP. Cyclic because it has a ring structure that activates smooth muscle relaxation. GMP, guanosine monophosphate. Mono means 1 phosphate left after breakdown. Big takeaway: nitrates LDH2 releases NO. NO activates guanylyl cyclase. GTP turns into CGMP. CGMP relaxes vessels. Blood flows better. Heart workload decreases. Does that help connect the dots?
Interesting. Yeah, thank you. That was very helpful. So myosin LCPO4 and myosin LC. How do these connect to all of this?
Great follow-up. Myosin LCPO4, phosphorylated myosin light chain, and myosin LC, dephosphorylated myosin light chain, are directly involved in smooth muscle contraction and relaxation. How they connect to CGMP and vasodilation. 1. Normally, myosin LCPO4 phosphorylated keeps the smooth muscle contracted, meaning the blood vessel is narrow. 2. CGMP, which was activated by NO and guanylyl cyclase, stimulates an enzyme called myosin light chain phosphatase, MLCP. 3. MLCP removes the phosphate group from myosin LC PO, turning it into myosin LC, dephosphorylated form. 4. Dephosphorylated myosin LC means the muscle relaxes, leading to vasodilation and increased blood flow. Big picture: phosphorylated myosin LC PO SWR, contraction, narrow vessels, higher BP. Dephosphorylated myosin LC relaxation, wider vessels, lower BP, better oxygen delivery. CGMP activates MLCP, which removes the phosphate and causes relaxation. So nitrates work by boosting NO, which increases CGMP, which deactivates myosin LCPO4, letting blood vessels relax and open up. Make sense?
Yeah, so why does dephosphorylating myosin LCPO4 mean relaxation?
Great question. Dephosphorylating myosin LCPO4 leads to relaxation because phosphorylation is what allows myosin to interact with actin and cause contraction. Let's break it down. 1. For contraction to happen, myosin light chain, myosin LC, must be phosphorylated, myosin LCPO4. This phosphorylation is done by myosin light chain kinase, MLCK, using ATP. Once phosphorylated, myosin can bind to actin, generating force and contracting the smooth muscle. 2. For relaxation to happen, CGMP activates myosin light chain phosphatase, MLCP. MLCP removes the phosphate from myosin LCPO4, turning it back into myosin LC. Without phosphorylation, myosin can't bind to actin, so contraction stops and the muscle relaxes. Big picture: phosphorylated myosin LCPO4, actin binding, contraction, vessels narrow. Dephosphorylated myosin LC, no actin binding, relaxation, vessels widen. This is why nitrates work. They boost NO, CGMP, MLCP activation, myosin dephosphorylation, vasodilation. That clear things up?
Not really, to be honest. Let's go nice and slow, piece by piece.
No problem. Let's go step by step, slow and clear. Step 1, what is myosin and why does it matter? Myosin is a motor protein that helps muscle cells contract. In smooth muscle, like in blood vessels, myosin works by pulling on actin filaments to make the muscle contract, which narrows the blood vessel. Step 2, what needs to happen for myosin to work? Myosin can't contract on its own, it needs to be activated first. To activate myosin, a small part of it, called the myosin light chain or myosin LC, needs to get a phosphate group added to it. This process is called phosphorylation, and it's done by an enzyme called myosin light chain kinase, MLCK. Step 3. What happens when myosin is phosphorylated? When myosin LC gets phosphorylated, myosin becomes active. Active myosin grabs onto actin, and the muscle contracts, making the blood vessel narrower. Step 4, how do blood vessels relax? To stop contraction and make the blood vessel relax, myosin needs to be turned off. This happens when an enzyme called myosin light chain phosphatase, MLCP, removes the phosphate from myosin LCPO4. Without the phosphate, myosin lets go of actin and the muscle relaxes. A relaxed muscle means the blood vessel widens, vasodilation, improving blood flow. Step 5. How does cGMP fit into this? Nitric oxide NO increases levels of cGMP in smooth muscle cells. cGMP activates MLCP, which removes the phosphate from myosin LCPO. Dephosphorylated myosin means no contraction, muscle relaxes, blood vessel dilates. Final summary, big picture. 1. Phosphorylated myosin LCPO core, myosin binds to actin, muscle contracts, blood vessel narrows, vasoconstriction. 2. Dephosphorylated myosin LC, myosin can't bind to actin, muscle relaxes, blood vessel widens, vasodilation. 3. No cGMP MLCP activation, myosin dephosphorylation, vasodilation, better blood flow, less heart strain. Does this explanation help? We can
Wow.
slow down even more if needed.
Wow. So what's confusing me a bit is kind of the order of things, because I haven't understood yet. You could have said these things the opposite way, and I wouldn't know to correct you. Like, why does GTP go to CGMP and then that goes to GMP? And why is myosin? I know you might have mentioned, but I haven't really understood it. Why does myosin LCPO4 equal contraction and myosin LC equal relaxation? Also, I wanted to ask about PDE, which makes CGMP to GMP. Is there anything to do here with sildenafil and like a lowering of blood pressure? This has something to do with Viagra, right?
Great questions. Let's take it slow and clear, starting with the order of events, then why myosin LCPO4 causes contraction, and finally how PDE and Viagra fit into this. 1. Why does GTP become CGMP and why does CGMP turn into GMP? This follows a natural enzymatic sequence of activation and deactivation. 1. GTP, guanosine triphosphate, CGMP, cyclic GMP. Why? Guanylyl cyclase, an enzyme inside smooth muscle cells, converts GTP into CGMP when nitric oxide NO is present. What does CGMP do? It triggers muscle relaxation by activating MLCP, myosin light chain phosphatase, which stops contraction. 2. CGMP, guanosine monophosphate. Why? Another enzyme, PD5 phosphodiesterase 5, breaks down CGMP into GMP. What does this do? GMP is inactive, so this stops the relaxation signal, allowing muscles to contract again. Think of CGMP as a relax signal and PD5 as the off switch. Why does myosin LCPO cause contraction and dephosphorylated myosin LC cause relaxation? This is all about whether myosin can bind to actin, which controls muscle contraction. 1.
Ah,
Phosphorylated
okay,
myosin,
got it.
myosin LCO equals contraction. When myosin is phosphorylated, it undergoes a shape change that allows it to bind to actin.
Hmm.
Once myosin binds to actin, it pulls on the muscle filaments, making the muscle contract and narrowing the blood vessel. 2. Dephosphorylated myosin, myosin LC equals relaxation. When myosin loses its phosphate dephosphorylation, it can't bind to actin anymore. Without this binding, there's no pulling force, so the muscle relaxes and the blood vessel widens, vasodilation.
Okay, this makes a lot more sense.
Where does PD5 fit in? What does Viagra sildenafil do? This is where Viagra and blood pressure come in. PD5, phosphodiesterase 5, normally breaks down CGMP into GMP, stopping relaxation. Sildenafil Viagra is a PDE5 inhibitor. It blocks PDE5 from breaking down CGMP. More CGMP stays in the system, keeping blood vessels relaxed for longer. This lowers blood pressure and improves blood flow. which is why Viagra is also used for pulmonary hypertension and not just erectile dysfunction. Final big picture summary. 1. No activates guanylyl cyclase, converts GTP to cGMP, muscle relaxes, vasodilation. 2. cGMP activates MLCP, removes phosphate from myosin LCPO4, myosin lets go of actin, muscle relaxes, vessel widens. 3. PD5 breaks down cGMP into GMP, relaxation stops, contraction returns. 4. Sildenafil blocks PDE5, so cGMP stays longer, keeping blood vessels relaxed. Does that help clear up the order and how everything connects?
Yeah, dude, that makes a lot more sense. Also, you should start a rap career. You speak so fast. Yeah, that was so helpful. Thanks. So, okay, a few other questions have risen in my mind, but this is becoming more clear now. So we've talked about mitochondrial aldehyde dehydrogenase 2, but why is it so effective in turning nitrate into nitric oxide? One. Also, what in the structure of nitric oxide makes it effective for this, and what in the structure of nitrates makes them ineffective for relaxation? And then I would like to ask, what exactly does guanylyl cyclase do to transform GTP to cGMP? Also, why is cGMP structure really good to help out the dephosphorylation, but GMPs isn't? And yeah, that's about it basically from my questions. Guys, by the way, I want to remind you, if you have any questions, leave them in the comments. And, I'm not going to answer them. ChatGPT is, and I'm just going to copy paste what ChatGPT says. But the amazing thing is you can do it by yourselves. And this is kind of one of the things the podcast teaches you. Well, as a disclaimer, we never know how accurate information is. But from my experience, ChatGPT has been better than a lot of teachers that I had. But yeah, I want to keep it nice and, yeah, anyway.
Man, I love the energy, and I appreciate the rap career suggestion. I'll stick to spitting science for now. Let's hit your questions one by one. Why is MTALDH2, mitochondrial aldehyde dehydrogenase 2, so effective at turning nitrates into nitric oxide? MTALDH2 has a unique enzyme structure that allows it to cleave nitrate NO3 molecules and release nitric oxide NO. It does this by breaking nitrates nitrogen-oxygen bonds in a controlled way, turning it into an active vasodilator. This enzyme is highly active in vascular smooth muscle mitochondria, where we actually need NO for vasodilation. What in the structure of nitric oxide NO makes it effective for vasodilation? Small size NO is a tiny diffusible gas, so it easily crosses cell membranes and spreads fast. Unpaired electron radical nature makes NO highly reactive, perfect for quickly triggering guanylyl cyclase. Direct enzymatic activation, NO doesn't need modifications. It immediately binds guanylyl cyclase to start the relaxation cascade. What in the structure of nitrates, NO3 moles, makes them ineffective for direct relaxation? Nitrates are stable molecules with strong nitrogen-oxygen bonds, meaning they can't directly release NO. The body must metabolize nitrates first using MTALDH2 to break them down into bioavailable NO. Without this enzymatic conversion, nitrates wouldn't trigger vasodilation at all. What exactly does guanylyl cyclase do to transform GTP into cGMP? Guanylyl cyclase is an enzyme that adds a cyclic phosphate bridge to GTP, creating cGMP. Normally, GTP, guanosine triphosphate, has a linear phosphate chain. Guanylyl cyclase removes two phosphates and rearranges the remaining phosphate into a ring, forming cGMP cyclic GMP.
So much information.
This cyclic shape is key. It makes cGMP an active messenger molecule. Got it. 1. MALDH2 breaks down nitrates by cleaving nitrogen-oxygen bonds, releasing NO, which is needed for vasodilation. 2. NO is small, reactive, and directly activates guanylyl cyclase, making it perfect for quick blood vessel relaxation. 3. Nitrates are too stable to work alone, so they need M to ALDH2 to convert them into NO first. 4. Guanylyl cyclase converts GTP to cGMP by forming a cyclic phosphate ring, making cGMP an active messenger. 5. cGMP activates MLCP, which removes phosphate from myosin LCPO4, stopping contraction and relaxing blood vessels. 6. GMP is inactive because it lacks cGMP's cyclic structure.
Okay, interesting. Well, guys, this is a hard topic. We could even do a whole hour or 2 hour video on the mechanism of nitrate drugs. So let's go forward. So, but if you want it, let me know in the comments. or ask ChatGPT yourselves for 2 hours, which is a really nice indirect thing I want to kind of say to you guys. We can use these tools, this technology to kind of, learn. And okay, let's talk about regulation of cardiac workload then.
Great transition. Cardiac workload is regulated by preload, afterload, heart rate, and contractility. Preload is the blood returning to the heart. Afterload is the resistance the heart pumps against, and both affect oxygen demand. Drugs like nitrates, beta blockers, and calcium channel blockers help reduce workload by lowering these factors.
I see. So basically, they're going to lower the volume of the blood returning to the heart, for instance, and that's gonna um, re- that's gonna affect the preload. Is it going to lower the preload?
Exact. Nitrates lower preload by dilating veins, which reduces the amount of blood returning to the heart. Less blood filling the ventricles means less stretch and lower oxygen demand. This helps relieve angina and reduce cardiac workload.
And so they're going to dilate the veins, which means that more blood is going to be flowing towards the more blood is going to be going towards the heart muscle, no?
Not exactly. Venous dilation reduces the amount of blood returning to the heart, meaning less preload and less strain on the heart. This actually lowers oxygen demand rather than increasing blood flow to the heart muscle. Arterial dilation, on the other hand, would help improve blood supply to the heart.
I'm a bit confused in regard to how they lower the preload from vasodilating venules.
I got you. Venous dilation increases the capacity of veins, so more blood stays pooled in the veins instead of returning to the heart. This means less blood fills the ventricles, reducing preload and decreasing the heart's oxygen demand. Less preload equals less stretch, less work, and lower cardiac strain.
I see. And what about heart rate? The heart rate, I assume, is regulated by the sympathetic nervous system. And how can calcium ions regulate heart rate?
Yes, heart rate is controlled by the sympathetic nervous system, which increases it through calcium influx into heart cells. Calcium ions help trigger stronger and faster contractions by activating troponin and myosin in cardiac muscle. Calcium channel blockers slow heart rate by reducing calcium entry, leading to weaker contractions and lower oxygen demand.
Okay, and I assume it's same with heart contractility.
Go ahead, I'm
And
with you. What's on your mind?
yeah, and heart contractility, is it the same thing with heart rate or is it slightly a different term?
Contractility and heart rate are related but not the same. Heart rate is how fast the heart beats, while contractility is how forcefully the heart muscle contracts. Calcium increases both, but drugs like beta blockers and calcium channel blockers can reduce contractility to lower oxygen demand.
Okay, so what about the RAAS? We can't not mention this. So how does that affect preload, total peripheral resistance, and does it affect heart rate and heart contractility?
Great question. The RAAS, renin-angiotensin-aldosterone system, increases preload by promoting sodium and water retention, expanding blood volume. It also raises total peripheral resistance, TPR, by vasoconstriction via angiotensin II, increasing afterload. While RAS mainly affects blood volume and resistance, it can indirectly raise heart rate and contractility through increased sympathetic activation.
Interesting. Okay, let's talk a bit more about nitrates. So, yeah, could we talk a bit about GTN, glyceryl trinitrates, and all of that, please?
Absolutely. Glyceryl trinitrate, GTN, is a rapid-acting nitrate used to relieve angina by dilating blood vessels. It works by releasing nitric oxide, and NO, which activates guanylyl cyclase, increasing CGMP and leading to smooth muscle relaxation. GTN is often given sublingually for quick absorption and fast relief.
Interesting. So, GTN, how exactly does it release nitric oxide? Does something break from the molecule?
Yes. GTN releases nitric oxide, NO, through enzymatic breakdown inside cells. The key enzyme TALDH2, mitochondrial aldehyde dehydrogenase 2, cleaves nitrate groups MySNO3 from GTN, converting them into NO. This free NO then activates guanylyl cyclase, leading to vasodilation and reduced cardiac workload.
I see. Interesting. Okay. And do we have short-lasting and long-acting nitrates, or are sorry guys, or are all nitrates the same thing?
Gotcha. Nitrates come in short-acting and long-acting forms. GTN, glyceryl trinitrate, is short-acting, used for quick angina relief, while isosorbide mononitrate and isosorbide dinitrate are long-acting, used for angina prevention. The difference is how fast they release nitric oxide, NO, and how long they stay in the body.
And where do we get these two names from? Isodorbide dinitrate and isosorbide mononitrate. And why are these two long-lasting, long-acting? What is it? The structure that's the difference?
Great question. The names isosorbide dinitrate and isosorbide mononitrate come from their chemical structures. Isosorbide is the core molecule, and dinitrate, or mononitrate, refers to the number of nitrate minus NO3 groups attached. Why are they long-acting? Their chemical structure releases nitric oxide, NO, more slowly compared to GTN, leading to a gradual and prolonged effect rather than a rapid one. Mononitrate is even longer acting than dinitrate because it's metabolized more slowly in the liver.
I see. And what exactly makes them what exactly is the reason that we don't just give nitric oxide straight?
We can't give nitric oxide, NO, directly because it's a gas that's highly unstable and has a very short half-life in the body. Nitrates act as NO donors, providing a more controlled and sustained release inside vascular smooth muscle. This ensures effective vasodilation without NO disappearing too quickly.
Can you explain it one more time?
Of course, we don't give NO directly because it's a gas that's too unstable and breaks down almost immediately in the bloodstream. Nitrates like GTN and isosorbide act as NO donors, releasing NO in a controlled, sustained way inside smooth muscle cells. This ensures effective vasodilation without NO disappearing too fast.
Interesting. That makes sense. And can we understand? I want us to understand the etymology of. Sorry for the noise, guys. Of the isosorbide mononitrate and isosorbide dinitrate.
Great. Isosorbide comes from sorbitol, a sugar alcohol, because the drug's structure is derived from it. Mono in isosorbide mononitrate means it has one nitrate minus NO3 group, while di in isosorbide dinitrate means it has two nitrate groups. These nitrate groups determine how fast NO is released, with mononitrate breaking down more slowly for a longer effect.
One more time with the etymology.
Sure. Isosorbide comes from sorbitol, a sugar alcohol used as the base structure of the drug. Mononitrate means it has one nitrate nice NO3 group, while dinitrate means it has two nitrate groups. The number of nitrate groups affects how quickly the drug releases NO and how long it lasts in the body.
And so, if we have more nitrate groups, this means we release it faster.
Not necessarily. More nitrate groups don't always mean faster release, but they do affect how the drug is metabolized. Isosorbide dinitrate with two nitrates is metabolized into mononitrate, making it a two-step, slower process. Mononitrate, one nitrate, is already in its active form, so it's absorbed and lasts longer in the body.
So, is it like 12 to 24 hours for dinitrate and 8 hours for mononitrate?
Not quite. Isosorbide mononitrate lasts 12 to 24 hours, making it a true long-acting nitrate. Isosorbide dinitrate has a shorter half-life, around 4 to 6 hours, but lasts longer than GTN. Dinitrate is converted into mononitrate in the liver, which extends its effect, but not as long as mononitrate alone.
Guys, this is a good time to intervene. So, from my notes, I seem to have a different amount. It seems like dinitrate lasts more. It's great if you guys do your own research and let us know in the comments, but it's great to kind of call out these things sometimes. So apparently they're both effective really fast though, in like 30 minutes, and they can be taken orally as release tablets. But why do we take them orally?
Great point. We take isosorbide mononitrate and dinitrate orally because they have better bioavailability than GTN, which is broken down too quickly by the liver. Oral formulations provide a controlled, extended release, making them effective for long-term angina prevention. GTN, on the other hand, is taken sublingually for rapid relief because it avoids first-pass metabolism.
Interesting. And any unwanted effects of taking nitrates?
Yes. Common side effects of nitrates include headaches, dizziness, hypotension, low blood pressure, and reflex tachycardia. These happen because of sudden vasodilation, which drops blood pressure and can trigger the heart to beat faster. Tolerance can also develop with prolonged use, so nitrate-free intervals are recommended.
Interesting. And why do we get headaches, dizziness, and postural hypotension? Even reflex tachycardia, apparently.
These side effects happen because nitrates cause widespread vasodilation, reducing blood pressure. Headaches occur due to dilation of cerebral blood vessels. Dizziness and postural hypotension happen because less blood reaches the brain when standing up. And reflex tachycardia is the body's way of compensating for low blood pressure by increasing heart rate. This is why nitrates must be used carefully in people prone to hypotension.
So, can we use something like bisoprolol to a beta blocker, basically, if we have this reflex tachycardia? What's the difference between normal tachycardia and reflex tachycardia? Also, why does prolol mean beta blocker? Why did they choose this suffix?
Yes, bisoprolol, a beta blocker, can be used to control reflex tachycardia caused by nitrates by blocking bond receptors in the heart, slowing the heart rate. Reflex tachycardia happens when low blood pressure triggers the sympathetic nervous system, while normal tachycardia can be due to stress, fever, or exercise. Prolol is a common suffix for beta blockers because it follows the naming convention for beta-adrenergic antagonists like metoprolol and propranolol.
Interesting. Okay, let's continue. So actually, I'm gonna stay just for one more moment. I don't understand how they find these suffixes. I don't know what the plural of suffix is. If it's yeah.
The plural of suffix is suffixes. These drug suffixes are set by international naming conventions to classify drugs by function. Prolol is used for beta blockers because early drugs like propranolol set the pattern, and later drugs kept the naming style for consistency. The same happens with other classes like pril for ACE inhibitors, e.g. enalapril, and sartan for ARBs, e.g. losartan.
Interesting. So let's talk a bit more about beta blockers. So do beta blockers block beta 1 and beta 2 receptors? Do we have any more receptors except beta 1 and beta 2? When it comes to the letter beta, what does each receptor do? And how are they connected to the RAAS? A lot to unpack here, but stay with me.
Är helt att du söker spela en beta
No, no,
vistaga
let's
och
stay in
en
English.
sticking to English. So, if you're asking about beta blockers and their effects on beta 1 and beta 2 receptors, here's the breakdown. Beta 1 receptors are mainly in the heart, increasing heart rate and contractility. Beta 2 receptors are found in smooth muscle, like in the lungs and blood vessels, causing relaxation when stimulated. Selective beta blockers like bisoprolol block only beta 1, while non-selective ones like propranolol block both, which can affect breathing by constricting airways. Let me know if that's what you meant.
That makes a lot of sense. So, what are some unwanted effects of beta blockers?
Beta blockers can cause bradycardia, slow heart rate, hypotension, low blood pressure, fatigue, dizziness, and cold extremities due to reduced circulation. Non-selective beta blockers like propranolol can also cause bronchoconstriction, worsening asthma or COPD. In some cases, they may lead to erectile dysfunction, sleep disturbances, or depression due to their effects on the nervous system.
What about bronchoconstriction and why do they cause fatigue?
Bronchoconstriction happens because non-selective beta blockers, like propranolol, block beta 2 receptors in the lungs, which normally help relax airway muscles. This can make breathing harder, especially for people with asthma or COPD. Fatigue occurs because beta blockers slow the heart rate and reduce cardiac output, meaning less oxygen and nutrients reach muscles and the brain, leading to tiredness.
Okay. Can you explain bronchoconstriction one more time? Because I'm a bit confused.
Of course, bronchoconstriction happens when the airway muscles tighten, making it harder to breathe. Normally, beta 2 receptors in the lungs relax these muscles, keeping airways open. Non selective beta blockers like propranolol block beta 2 receptors, preventing relaxation and causing airway narrowing, which can trigger wheezing and shortness of breath, especially in asthma or COPD patients.
Interesting. Okay. Um, can we go a bit deeper into this?
Definitely. Beta 2 receptors in the lungs trigger bronchodilation when stimulated by epinephrine, adrenaline, relaxing airway smooth muscle to open the airways. When a non selective beta blocker like propranolol blocks these receptors, it prevents this relaxation, leading to bronchoconstriction, where the airways narrow and breathing becomes harder. This is especially dangerous for people with asthma or COPD, as they rely on beta 2 stimulation to keep their airways open. Want to go even deeper into the molecular mechanisms?
We could do, but I think I'm covered. You could briefly go if you want to. I also wanted to ask you about peripheral vascular disease and how the beta blockers' effects might be contraindicated in patients with PVD.
Glad you're covered. Briefly, at the molecular level, beta 2 receptor activation increases CAMP, which inhibits myosin light chain kinase, MLCK, relaxing airway smooth muscle. Beta blockers block this process, leading to airway tightening, bronchoconstriction. As for peripheral vascular disease, PVD, beta blockers can worsen symptoms by reducing cardiac output and vasoconstriction in peripheral arteries, leading to cold extremities, pain, and worsened circulation.
And
Non-selective beta blockers are particularly problematic because blocking beta 2 receptors prevents vasodilation, further restricting blood flow to the limbs. That's why they're often avoided in severe PVD cases.
can you do a brief summary again of the correlation of PVD?
Sure, beta blockers can worsen PVD by reducing cardiac output and causing vasoconstriction, which limits blood flow to the limbs. Non-selective beta blockers are especially problematic because blocking beta 2 receptors prevents vasodilation, making symptoms like cold extremities, pain, and poor circulation worse. That's why they're often avoided or used cautiously in PVD patients.
I don't understand. Sorry, guys.
No problem. Let's break it down simply. Peripheral vascular disease, PVD, means narrowed blood vessels in the limbs, reducing circulation. Beta blockers slow the heart and lower blood pressure, which reduces blood flow to the already narrowed vessels. Non-selective beta blockers make it worse by blocking beta 2 receptors, which normally help widen blood vessels, leading to colder hands and feet, more pain, and worse circulation.
One last time. Sorry, guys, you can skip this part. Hopefully, I'll
Of course.
find time spams.
PVD means poor blood flow to the limbs due to narrowed arteries. Beta blockers lower heart rate and blood pressure, reducing circulation even more. Non-selective beta blockers worsen this by blocking beta 2 receptors, which normally help dilate blood vessels, leading to colder, more painful extremities.
So, why do the negative inotropic and chronotropic effects on the heart have this effect? I don't understand. Explain to me these words too, because I don't know them.
No problem. Let's break it down step by step. One, what does negative inotropic mean? Inotropic refers to the strength of heart contractions. Negative inotropic drugs, like beta blockers, weaken heart contractions, meaning the heart pumps with less force. Two, why does this affect PVD? If the heart pumps less forcefully, it sends less blood to the body, including the limbs. In PVD, blood flow is already reduced, so weaker heart contractions make the problem worse, leading to cold, painful extremities. Three, beta blockers also lower blood pressure, which further reduces circulation to the already narrowed arteries in PVD. Four, non-selective beta blockers block beta 2 receptors, which normally help dilate blood vessels, worsening the reduced blood flow. That's why beta blockers can be problematic in PVD patients. They weaken the heart's pumping and reduce blood flow to the limbs.
So the reduced cardiac will have reduced cardiac output, and then yeah, I'm still not sure. Can you explain what PVD is?
Reduced cardiac output, CO, means less blood is pumped out of the heart, leading to less circulation to the limbs. In PVD, where arteries are already narrowed, this worsens symptoms like cold, painful extremities. If a non-selective beta blocker is used, it also blocks beta 2 receptors, preventing blood vessel dilation, making circulation even worse.
And why do we say that it might precipitate or aggravate symptoms of arterial insufficiency? Can you decode this really hard phrase?
Yes, precipitate or aggravate symptoms of arterial insufficiency means it can trigger or worsen poor blood flow to the limbs. Arterial insufficiency means arteries can't deliver enough blood to tissues, like in PVD. Beta blockers lower cardiac output, reducing the amount of blood reaching the limbs. Non-selective beta blockers also prevent vasodilation, making arteries stay narrow, which worsens symptoms like pain, coldness, and cramping. So beta blockers can make an already bad circulation problem even worse by further reducing blood flow.
Interesting. So, what about calcium channel blockers now? Let's talk about how they affect the force of contraction and the frequency of contraction first.
Great. Calcium channel blockers, CCBs, reduce both the force and frequency of heart contractions by blocking calcium CH entry into heart muscle cells. One, force of contraction, inotropy. Calcium is essential for activating troponin, which allows actin and myosin to interact, leading to contraction. Blocking calcium entry reduces contractility, negative inotropic effect, weakening the heart's pumping force. Two, frequency of contraction, chronotropy. The SA node pacemaker relies on calcium for action potentials that set heart rate. Blocking calcium slows the SA node, reducing heart rate, negative chronotropic effect. That's why CCBs are useful in lowering blood pressure and reducing heart workload.
And how do non-dihydropyridines connect with all of this?
Non-dihydropyridines, like verapamil and diltiazem, directly affect the heart by reducing both contractility, force, and heart rate, frequency. One, they block calcium channels in cardiac muscle, leading to a negative inotropic effect, weaker contractions. Two, they slow calcium entry into the SA and AV nodes, causing a negative chronotropic effect, slower heart rate. Three, This makes them useful for treating hypertension, arrhythmias, and angina, but they should be used cautiously in heart failure due to their weakening effect on the heart's pump function.
Interesting. Okay, let's talk about the etymology of non-dihydropyridines. I can't even say it, guys, and their structure. How does the structure relate to the function?
Great question. Non-dihydropyridines break down like this. Non means they are not part of the dihydropyridine DHP class of calcium channel blockers. Dihydro refers to the addition of two hydrogen atoms in the structure of dihydropyridines like amlodipine, which primarily affect blood vessels. Pyridine is a six-membered ring with nitrogen, forming the core structure of dihydropyridines, but non-DHPs have a different structure. Structure differences. Dihydropyridines, e.g. amlodipine, have a dihydropyridine ring, making them act mainly on blood vessels. Non-DHPs, verapamil, diltiazem, lack this ring and act more directly on the heart, reducing heart rate and contractility. That's why non-DHPs are better for arrhythmias, while DHPs are better for hypertension.
Interesting. And can we talk a bit about verapamil, diltiazem? I can't even know these names. Phenylalkylamines and benzothiazepines. I really need an explanation of etymology here.
Absolutely. Let's break down the etymology and classification of verapamil and diltiazem step by step. 1. Verapamil, phenylalkylamine class. Phenyl refers to a benzene ring in its structure. Alkyl means it has a straight or branched carbon chain attached. Amine means it contains a nitrogen group, NH2 or similar. Verapamil is a phenylalkylamine, meaning it primarily affects the heart, reducing heart rate and contractility. Diltiazem benzothiazepine class. Benzo refers to a benzene ring in the structure. Thia means it contains sulfur, S. Zepine suggests a seven-membered ring, common in some medications. Diltiazem is a benzothiazepine, which means it affects both the heart and blood vessels, acting as a bridge between dihydropyridines, which act on vessels, and verapamil, which acts mainly on the heart. Key difference: verapamil, stronger heart effects used for arrhythmias. Diltiazem, mixed heart plus vessel effects used for both arrhythmias and hypertension. Now that you know the etymology, does it make more sense?
Kind of. Could you summarize it one more time for me?
Of course. Verapamil, phenylalkylamine class, phenyl, benzene ring, alkyl, carbon chain, amine, contains nitrogen. Mainly affects the heart, reducing heart rate and contractility, used for arrhythmias. Diltiazem, benzothiazepine class, benzo, benzene ring, thia, sulfur, zapine, seven-membered ring. Affects both heart and blood vessels, reducing heart rate and causing vasodilation, used for arrhythmias and hypertension. Verapamil's stronger heart effects, diltiazem's heart blood vessels.
But they don't even have the same suffix.
Unlike beta blockers, prolol, or ACE inhibitors, monopril, calcium channel blockers don't follow a single suffix pattern. Verapamil belongs to phenylalkylamines, a unique structure class. Diltiazem belongs to benzothiazepines, a different structure class. Dihydropyridines like amlodipine, nifedipine share the dipene suffix, but non-DHPs don't follow that rule. Since verapamil and diltiazem evolved separately, they didn't end up with a matching suffix, even though they both block calcium channels.
Okay. And how come we have a decrease in cardiac workload but an increase in dilation of arterioles? It seems contradictory to me.
Great question. It seems contradictory, but here's how it works. 1. Calcium channel blockers reduce cardiac workload by blocking calcium entry into heart cells, leading to weaker contractions, negative inotropy, and a slower heart rate, negative chronotropy. This lowers oxygen demand on the heart. 2. At the same time, they dilate arterioles by blocking calcium in vascular smooth muscle, causing vasodilation. This reduces afterload, meaning the heart has to push against less resistance, further decreasing its workload. So the heart works less, but blood flow improves because arterioles are wider, making it easier for blood to circulate.
Interesting. Interesting. So arterioles widen. It's easier for blood to circulate. Okay, now it makes sense. I think I got confused with cardiac workloads with kind of cardiac output, I think. So does output go up, or does it stay the same? It's just the workload that decreases.
Good catch. Cardiac output CO can stay the same or even slightly decrease depending on the drug.
Mhm.
1. If heart rate and contractility drop significantly, like with verapamil, CO may decrease. 2. If afterload arterial resistance drops a lot, like with dihydropyridines, CO may stay stable or slightly increase because the heart pumps more efficiently against less resistance. So cardiac workload decreases, but CO depends on the balance between heart rate, contractility, and afterload reduction.
Mhm. Interesting. Can we talk a bit about asthmatics now? So, if asthmatics or other groups where beta blockers are contraindicated, then what happens? Can we use can we use calcium channel
Yes.
blockers?
In asthmatics, non-selective beta blockers like propranolol are contraindicated because they block beta 2 receptors in the lungs, leading to bronchoconstriction and worsening asthma symptoms. If beta blockers are needed, cardioselective beta 1 blockers like bisoprolol or metoprolol are preferred since they primarily target the heart and have less effect on the lungs. For conditions like hypertension or angina in asthmatics, calcium channel blockers like diltiazem or amlodipine are often used instead since they don't interfere with airway function.
Interesting. Okay. And so, yeah, can we talk a bit about verapamil and diltiazem a bit more? So they are the ones that are going to be used in this case. Or why not amlodipine? Why is amlodipine better for hypertension?
Great question. Verapamil and diltiazem are preferred in asthmatics when beta blockers are contraindicated because they reduce heart rate and contractility, making them useful for arrhythmias and angina. Amlodipine, a dihydropyridine, mainly works on blood vessels to lower blood pressure, but it doesn't slow heart rate or reduce contractility like verapamil or diltiazem. So if the goal is heart rate control, like in arrhythmias, verapamil or diltiazem is better. If it's just for blood pressure, amlodipine works fine.
But why this difference? I don't get it.
The difference comes from where these drugs act. 1. Verapamil and diltiazem block calcium channels in the heart, reducing heart rate, negative chronotropy, and contractility, negative inotropy. This makes them useful for arrhythmias and angina. 2. Amlodipine, a dihydropyridine, mainly blocks calcium channels in blood vessels, causing vasodilation but without affecting heart rate or contractility. This makes it great for hypertension, but not for heart rate control. So if you need to slow the heart, you use verapamil diltiazem. If you just need to lower blood pressure, you use amlodipine.
So what makes one type of drug block the blood vessels and the other block the calcium on the heart muscle?
Great question. The difference comes from how these drugs bind to calcium channels and their selectivity for different tissues. 1. Verapamil and diltiazem, non-dihydropyridines, prefer the heart. These drugs bind more strongly to calcium channels in the SA and AV nodes pacemaker cells. This slows heart rate and weakens contractions, making them useful for arrhythmias and angina. 2. Amlodipine dihydropyridine prefers blood vessels. It binds more selectively to calcium channels in vascular smooth muscle. This causes vasodilation, widening of blood vessels, lowering blood pressure without major effects on heart rate. The difference is in tissue selectivity. Verapamil diltiazem act more on the heart, while amlodipine acts more on blood vessels.
Yeah, could you in one or two sentences explain why what in the structure makes them go to these different locations?
Great question. The structural differences between dihydropyridines, like amlodipine, and non-dihydropyridines like verapamil and diltiazem determine their tissue selectivity. 1-amlodipine dihydropyridine, selective for blood vessels. It has a dihydropyridine ring, which makes it more lipophilic and able to bind preferentially to vascular smooth muscle calcium channels. These calcium channels are in an inactive state longer, and dihydropyridines bind best to inactive channels, making them ideal for vasodilation. 2. Verapamil and diltiazem, non-dihydropyridines, selective for the heart. Their bulkier structures, phenylalkylamine in verapamil, benzothiazepine in diltiazem, allow them to preferentially bind to open calcium channels in the SA and AV nodes, slowing conduction. They have a higher affinity for cardiac muscle calcium channels, leading to heart rate reduction and lower contractility rather than vasodilation. In short, amlodipine binds to inactive calcium channels in blood vessels, causing vasodilation. Verapamil and diltiazem bind to active calcium channels in the heart, slowing heart rate and contractility.
Got that part, and sorry for sticking to this for so long, guys, but what I'm asking is, how come, I mean, maybe you've already answered it and I didn't understand, but how come one goes to the heart, the other goes to blood vessels? In a sentence, if you could explain why they have this difference in affinity.
The difference in affinity comes from how these drugs bind to different states of calcium channels. Amlodipine dihydropyridine binds better to inactive calcium channels, which are more common in vascular smooth muscle, making it
Okay.
selective for blood
Right.
vessels.
Got it.
Verapamil and diltiazem, non-dihydropyridines, bind better to open calcium channels, which are more active in cardiac pacemaker and muscle cells, making them selective for the heart. That's why amlodipine causes vasodilation, while verapamil diltiazem slow the heart.
Got it. Great. And now let's talk a bit about the different calcium channels. We have L type. What other types do we have?
Great. There are several types of calcium channels, but the most important ones in the cardiovascular system are 1. L-type, long-lasting, found in heart muscle, blood vessels, and smooth muscle, targeted by calcium channel blockers like amlodipine, verapamil, and diltiazem. 2. T-type, transient, found in pacemaker cells, SA and AV nodes, and some neurons involved in regulating heart rate. 3. N-type, neuronal, found in nerve endings involved in neurotransmitter release. 4. PQ-type and R-type, found mostly in neurons controlling synaptic transmission. L-type channels are the main target of calcium channel blockers because they regulate heart contraction and blood vessel tone.
One more time, please. Sorry, guys.
No problem. Here's a quick recap. 1. L-type, long-lasting, found in heart muscle, blood vessels, and smooth muscle, targeted by calcium channel blockers. 2. T-type, transient, found in pacemaker cells, SA and AV nodes, helping regulate heart rate. 3. N-type, neuronal, found in nerve endings, controlling neurotransmitter release. 4. PQ-type and R-type, found mainly in neurons involved in synaptic transmission. L-type channels are the main target for heart and blood vessel drugs.
Wait, are you sure about? So, guys, my notes say something different personally in my script. So, are you sure that it's L-type channels in the, sorry, T-type channels in the SA and AV nodes? Do calcium channel blockers reduce heart rate by blocking L-type channels in the SA and AV nodes or T-type?
Great catch. Calcium channel blockers reduce heart rate by blocking L-type calcium channels in the SA and AV nodes, not T-type. L-type channels are found in cardiac muscle and pacemaker cells and are responsible for strong, sustained calcium influx needed for contraction and conduction. T-type channels do exist in the SA and AV nodes, but are more involved in pacemaker activity at lower voltages rather than conduction strength. Verapamil and diltiazem block L-type channels in the SA and AV nodes, slowing depolarization and reducing heart rate. So yes, CCBs work by blocking L-type calcium channels in the SA and AV nodes, not T-type.
And why do these L-type and T-type are found in different areas? And what does T-type stand for?
T-type, transient, and L-type, long-lasting, calcium channels are found in different areas because they serve different functions in electrical signaling and muscle contraction. 1T-type transient channels found in pacemaker cells, SA and AV nodes, and some neurons. Open at lower voltages and help with early depolarization in pacemaker activity. Allow a short, weak calcium influx to help regulate rhythm, but not contraction force. 2 L-type long-lasting channels found in cardiac muscle, vascular smooth muscle, and SAAV nodes. Open at higher voltages, providing strong, sustained calcium influx for contraction. These channels are the main target of calcium channel blockers to slow heart rate and relax blood vessels. In short, T-type equals fast, weak calcium flow, rhythm control. L-type equals strong, sustained calcium flow, contraction, and conduction.
One more time about the T type and the L type.
Sure. 1T-type transient calcium channels found in SA and AV node pacemaker cells and some neurons. Open at low voltages, allowing short, weak calcium influx to help regulate rhythm but not contraction force. Important for early depolarization in pacemaker activity. 2 L-type long-lasting calcium channels found in cardiac muscle, vascular smooth muscle, and pacemaker cells. Open at higher voltages, providing strong, sustained calcium influx for muscle contraction and electrical conduction.
So why are they called transient? What does that mean?
They're called transient because they open for a short time during early depolarization and then quickly close. This brief calcium influx helps initiate pacemaker activity but doesn't sustain contraction like L-type channels do.
So what does transient mean in a sentence?
Transient means short-lived or temporary, referring to how T-type calcium channels open briefly and then close quickly during early depolarization in pacemaker cells.
Oh yeah, but what's the etymology of transient?
Are called transient because they open and close quickly, allowing brief calcium
I
entry
got
into
that.
cells. This rapid action is essential for generating rhythmic.
Tell me again what transient exactly means.
Transient comes from the Latin transire, meaning to pass across or to go beyond. It describes something temporary or short-lived, like T-type calcium channels, which open briefly and close quickly.
Okay, amazing. Now I'm getting it. Let's talk about, sorry guys, I'm a bit tired. But again, this kind of podcast is basically my medical journey with you guys. And you're gonna see me in ups and downs. So yeah, let's talk about ivabradine now.
Great. Ivabradine is a drug that reduces heart rate without affecting contractility. It works by blocking the funny if channels in the SA node, slowing pacemaker activity, and decreasing heart rate. This makes it useful for heart failure and angina when beta blockers aren't tolerated.
So why are blockers not tolerated in angina? Why does ivabradine reduce pacemaker current? Why is pacemaker current called IF? What's the etymology of ivabradine? A lot of questions. Please just give us 3 sentences. We're a bit dumb and tired at the moment, at least I am.
Because they can cause excessive bradycardia, fatigue, or bronchoconstriction, especially in asthma. Ivabradine reduces pacemaker current if by blocking funny channels in the SA node, slowing heart rate without lowering contractility. The if current stands for funny because it has unusual activation properties, opening during hyperpolarization instead of depolarization.
Hmm. And why does ivabradine reduce sodium entry? Also, you didn't tell me about the ivabradine etymology.
Ivabradine reduces sodium entry by blocking the funny if channels, which normally allow a slow influx of sodium that helps generate pacemaker activity in the SA node. By inhibiting this current, ivabradine slows the heart rate without affecting contractility. The name ivabradine doesn't have a clear etymology, but follows drug naming conventions, likely derived from its chemical structure and function.
So it blocks the IF channels, and why does it do it in the nodal tissue of the heart?
Ivabradine blocks if channels in the SA node because these channels are primarily found in pacemaker cells and are responsible for controlling heart rate. If channels allow sodium entry during hyperpolarization, gradually bringing the cell to threshold for the next heartbeat. By blocking these channels, ivabradine slows spontaneous depolarization, reducing heart rate without affecting contraction strength.
Interesting. Okay, what are the side effects of ivabradine? Dizziness, perhaps bradycardia, visual aura, luminous phenomena, phosphines. What are all these?
Yes, ivabradine's side effects include bradycardia, slow heart rate, dizziness, and visual disturbances like luminous phenomena, phosphines, where patients see bright flashes. This happens because ivabradine also affects retinal/eyes if channels, altering light perception. Other side effects can include fatigue and hypotension.
Interesting, interesting. And you said it's called funny because does something in hyperpolarization instead of depolarization. And if I remember correctly, the whole RST or QRS, sorry, the whole QRS complex is depolarization, right?
Yes, the funny if current is unusual because it activates during hyperpolarization when most other channels are closed, instead of depolarization. This allows a slow influx of sodium, gradually bringing the SA node cells to threshold for the next action potential.
Hmm.
That's why, if channels are crucial for pacemaker activity and heart rate regulation.
I see. Can we talk a bit about nicorandil?
Yes, nicorandil is a drug that acts as both a nitrate and a potassium K channel opener, helping to relax blood vessels and reduce heart workload. It dilates coronary arteries, improving oxygen supply, and reduces afterload, lowering heart strain. It's mainly used for angina, especially when other treatments aren't tolerated.
And what's its etymology then?
The exact etymology of nicorandil isn't well documented, but it likely comes from neco, referring to nicotinamide, a structural component of the drug. Randil, possibly related to its function as a potassium channel opener and vasodilator. Its name follows pharmaceutical naming conventions, reflecting its dual action as a nitrate donor and K-Puis channel opener for angina treatment.
Interesting. Okay. And let's talk a bit more about nicorandil. So it acts as a vasodilator via two mechanisms. Can you tell us these two mechanisms?
Yes, nicorandil acts as a vasodilator through two mechanisms. One, nitrate-like effect. It releases nitric oxide, NO, which increases cGMP, leading to vascular smooth muscle relaxation and vasodilation. Two, potassium K channel activation. It opens ATP-sensitive KP channels, causing hyperpolarization of vascular smooth muscle cells, reducing calcium entry and promoting further vasodilation. This dual action makes it effective for angina by reducing both preload and afterload while improving oxygen supply.
Interesting. So, okay, so we have two ways then. We have um it you said nitric oxide or potassium channel opener?
Exactly. Nicorandil works in two ways. One, nitric oxide release increases cGMP, leading to smooth muscle relaxation and vasodilation. Two, potassium K-mol channel opening causes hyperpolarization, reducing calcium entry and further relaxing blood vessels. This dual
Hmm.
effect makes it great for angina as it improves blood flow while lowering heart workload.
Hmm. Interesting. And why is it that it acts as a potassium channel opener at higher concentrations, but as a nitrate at lower concentrations?
You have reached the message cap for
I got you. So, Nicorandil acts as a nitrate at low concentrations by donating nitric oxide, which increases cGMP and relaxes vascular smooth muscle. At higher concentrations, it opens ATP sensitive potassium channels, causing hyperpolarization and further vasodilation. This dual action helps improve blood flow to the heart in ischemic conditions.
One more time, I didn't understand how come this is possible. How does it know the concentration to act to use potassium channel opener or nitrate?
Great question. It doesn't know, it's about how much of the drug is present. At low doses, enough Nicorandil reaches the nitrate pathway to release nitric oxide and cause vasodilation. As you increase the dose, more of it starts binding and activating potassium channels because now there's enough concentration to affect both systems. So it's a matter of affinity and how many molecules are available to act on each target. Does that make more sense?
Yeah, that makes more sense. Any side effects of Nicorandil and why? Can we talk about ulceration of the lower GI tract about it too?
Yeah, totally. So, common side effects of Nicorandil include headaches and flushing because of too much vasodilation. Basically, blood vessels relax too much. Now, about the ulceration, Nicorandil can cause serious ulcers, especially in the mouth, skin, and lower GI tract. The exact reason isn't fully known, but it might be because its nitrate part and potassium channel activation together impair healing or reduce blood flow in certain tissues, making them more prone to breakdown. Crazy for a heart drug, right?
Mm-hmm. Let's end this podcast by talking about treatments for ischemic heart disease.
Yeah, awesome way to wrap it up. So, treatments for ischemic heart disease focus on reducing oxygen demand and improving oxygen supply to the heart. First line drugs include beta blockers to slow the heart rate, nitrates like GTN for vasodilation, calcium channel blockers to relax vessels, antiplatelets like aspirin to prevent clots, statins to lower cholesterol, and ACE inhibitors for long term protection. And of course, lifestyle changes like diet, exercise, and stopping smoking are huge in managing the disease. Should we add something on revascularization like stents or CCABG, or leave it
No,
here?
this is great. This is great. I'm tired, guys. But this was a good podcast, although I think I got a bit tired in the end. I'm sorry, guys. Again, this is my medical journey, so you'll see me in vulnerable times too. I hope you enjoyed it. Any topics you ever want to cover, just let me know in the comments. Love you guys and girls, and I'll see you at the next episode. ChatGPT, to wrap it up, any last words?
Ah, that was beautiful. Yeah, just to say, I love how real you are about the journey. Medicine isn't easy, and showing that makes it even more inspiring. Keep going, and to everyone listening, keep learning and being curious. See you next time.
Yes, sir. See you guys. Love you.